Okay, good morning, everyone. We will start this fifth echo session for dialogues for viral hepatitis elimination that we have started about half a year ago. Hello and good morning, good afternoon, good evening to everyone. So we started these sessions to have a country dialogue, mainly with around 35 key countries. And as I said, this is the fifth session. We had previous sessions on prevention of mother to child transmission, strategic national plans, the hepatitis B guidelines, and input from country colleagues. Today is the session is on the global reporting for viral hepatitis in 2023. And for this, our colleagues from the Strategic Information Unit asked new and additional participants to join. So we welcome very warm-heartedly other participants that work in strategic information and who join us for this and possibly as well the next webinar series. So as I said already before, but we'll say again, please introduce yourself in the chat and maybe just put your name and your affiliation in the chat so that we know who is online. Can we continue with the slides? Yeah, next one. So again, very warm welcome. Just very quickly so that you're orientated on what is gonna happening today. I am stepping in for Professor Leschi, who is the cross-cutting lead for our global hepatitis program, but she's on leave today. So I will co-chair this session and welcome you. We will have then the welcoming remarks from the unit lead in strategic information, Daniel Lobeer, and presentation from Diana, and they and Fu Chang will stay for questions and answers. And we will have as well a video presentation from the CDA Foundation, still on the topic on global reporting. And then we have good amount of time for question and answers and some poll questions. That one will be chaired by our regional colleague, Casimir Manzengo from the Afro region, WHO Afro region, together with Sandy and Diana, and we will close the session. So again, next slide. So just a very few housekeeping pieces. Many of you might know if you have joined other of those webinars or similar webinars. First of all, there is interpretation for French. I've seen, for example, that a colleague from Morocco is on. As always, you find an interpretation button in the bottom of the Zoom where you can then choose your language. If you prefer to have live captation on, that is as well an option in the bottom tool line of the Zoom, so you can show captions if that helps you understanding some of the informations. Very important, obviously there's the chat function, but really for those who have not joined, this is a very interactive format. It is actually really for sharing and learning, and so we want you not to hesitate at any time to put your comments, observations, or questions in the chat, and you can raise your hand anytime. We are very happy for all kinds of contributions, and we had very active sessions before. Next slide. As well, in terms of, I think you maybe now presented yourself in the chat, but please rename yourself as well in the participants list. You go to participants. If you see your list, you can find a rename button, or you click right, I think, and then please put your list how it is shown. Name, first name, and then country of origin or work as you prefer, possibly country of work in there. The session is being recorded, so if you have any opposition to that, then please let us know. Next slide. So without further ado, let us move into the content, which is very exciting and very important and a very key role of WHO to really report and gather information on viral hepatitis across the globe. And for further opening remarks, over to you, Daniel.
So thank you, and just to say it's a great privilege to have a dialogue on data and with people in the countries and such a broad range of people. And I'm in charge of strategic information across HIV, hepatitis and STIs, but our #1 priority this year is global reporting on viral hepatitis. So more important than HIV data is getting the data on hepatitis, the burden data, and also consistent data in countries that can be used for planning. And maybe just two things on that. We had a report in 2021, which was very important in showing the burden of hepatitis, the increased burden of hepatitis B, and also accountabilities and baselines for our strategies. So it's a very important moment to look at how we're progressing. The 2025 targets are not that far away, so this reporting is very important. And what's new, so the first point is what's new is we really want to get country validated data so that there will be a set of data in countries which is reported, is accepted, is used by ministries of health, and so that all partners can help support that scale up, because we really want to see action based on data in countries. So really what's new is this dialogue on data through to countries with the Ministry of Health. And we want at the end to have a validated set of country data that everyone can use to support those countries. And then secondly, we've allowed a little bit more time for the reporting this year. So the deadline is the 30th of September, but it is to use that time. And first of all, it is to have a dialogue on how we can strengthen M&E systems for hepatitis within the countries. So you'll see a block there for comments on what are your priorities to improve data, because we know there are gaps. And also to provide some contextual information on where you see there are uncertainties in data. And then secondly, that allows us to get the best quality background data from the literature, from partners, and provide it to you. So there is a file of background data for the country, and we're working on that. We will update that in July, so you'll have some data to refer to. And then maybe just 3 points on the process itself. You'll see in the letter there is a very clear algorithm for reporting, and at the basis of that is country reported data. So we want data that is accepted by the Ministry of Health. If you have your own data on these areas, please use that. The second part of the algorithm then, if there is some regional conferences, which the regional offices have done, I know Euro works closely with ECDC, or there's partner data. If you have blanks, then to look at that to see whether you can use some of the background data. And we put quite a lot of effort with partners to collect that. But then clearly, if you have gaps, you can then leave the data blank. But we would prefer really countries not to. We want to get as good reporting as possible, even if we know there are some limitations in the data. There will be some actions you put in there to strengthen your systems over time. Based on country data, looking at partner data, we'd like as complete data as possible in reporting. We're quite flexible in how you report as the second form. There's a form you can report using the attached form. We have an online system that Diana will also present. The important bit is the focus on the data, that you have that dialogue within the country where you need support from partners, the regional offices. We come out with a set of data that is reported at the end of this period. And then finally, this is data to be used. So we will then feed back this data to the countries, to the regions. We'll make it transparently available so people can help support the programs. And of course, we'll be producing reports which will add up the progress in treatment coverage, in diagnosis coverage, and in the burden of disease. And prioritize as much as you can. I mean, the minimum data we would certainly like is the treatment coverage. Look at the latest figures you've got on hepatitis B and hepatitis C. That's the scale up we need to see. Look at the burden data. It may not have changed hugely from the last period, but look at any updates you've got on that. And then thirdly, there are some policy questions this time as well, so we can tailor our support to countries. We can see where there are gaps in building in the data systems. So that's really it. That's a little bit of the background. We want to get us complete country data. We want it to be owned by the countries, but then we want to have a transparent set for which partners can work on in countries. And this is, for me, across our 3 diseases, probably the #1 priority this year is to get that updated data on global reporting for viral hepatitis. Thank you. Over to you, Diana.
Thanks, Daniel, for that very clear intro. So I'll hand over now to Diana Finey, who's leading the strategic information for viral hepatitis in Daniel's team, and she will take us through presentation and 2 videos, I think. Over to you, Diana.
Dinah, you are not audible.
Oh.
Apologies for that.
Was it turned off from the beginning?
I'm not sure.
You can ask. When did you hear Diana at the start of her intervention?
No, you were not audible from the beginning.
Please repeat.
Okay, I'll just go quickly back. I just say I'm presenting this on behalf of Ucheng and Daniel, who all of us have worked on the reporting platform and will be supporting countries and regions for the reporting this year. Our presentation will go over the reporting systems for viral hepatitis and specifically for the global reporting, the data to be reported, and processes and timelines. The presentation that follows will go in line with this to talk about the reporting, the online reporting tool, but also we'll have a presentation after mine from CDA on the estimates that are developed for regions and countries to be used for validation in countries. And to begin with, I wanted to just recap on what we have as reporting systems for viral hepatitis within WHO. Understandably, our indicators are shared across different stakeholders and units within WHO. For instance, hepatitis B vaccination coverage is reported jointly with UNICEF. We have data on harm reduction, infection controls that are reported through the Global AIDS monitoring, and some of you may have been involved in reporting this data just last month. So these are some of the platforms that we collect information on hepatitis. However, the global reporting for viral hepatitis is specifically there to collect information on the cascade indicators, on the number of people tested and treated, but we also collect more other information on hepatitis prevalence, incidence, as well as mortalities. So this system has been set to cover the gaps on the indicators that are relevant for hepatitis and are relevant to report in the framework of the global health sector strategy. The global reporting for viral hepatitis is, as mentioned, is there to allow countries to have a platform to track and monitor the progress towards elimination, as managed by the global health sector strategies. So we use this to help countries, as Daniel said, look at the data, have a dialogue on the data, and see where the performance is and plan ahead as relevant for the hepatitis reporting. And we'll see specifically why, what are the data that are asked for this reporting, which does help countries to look back on their burden, look on their service coverage, as well as the policy implementation, and plan the their programs ahead towards viral hepatitis elimination. To repeat a little about what Daniel had mentioned, the reporting started in 2018, where we got data from 2017 to 2018, where we had reports from 68 countries. Our last reporting was in 2021 with 2019 data, where we had an increase to 130 countries reporting data. We had seen during that reporting, and are still seeing, that data is available in most countries and service delivery points, but there is quite a lack of a system to collect this information and provide a platform to report consistently within countries. And therefore, this reporting, we're not only asking for countries to report, but we're also looking on the capacity of the countries in terms of the data systems and human resource capacity to collect, manage, and analyze data. And we're doing this concurrently with updating our guidelines, where we recommend how countries can build better the surveillance systems to be able to track their progress in real time, if I may say, and see how they are on track to eliminate viral hepatitis. So for this year, we have simplified the reporting to ensure that it's clear, and we have outlined a stepwise approach, clearly prioritizing country level data where it's available. We have aligned the reporting to what is requested for countries within regions. We understand, for instance, in countries in Euro, the indicators they report need to be concise and not overburden the ministries of health and reporting, and therefore we have aligned our platform for this, and similarly for regions such as PAHO. And for this reason, if I may note here that we understand for Euro, the memos to report the data may have not reached the country offices. That may still be with regions in some of the areas. We're doing this because we want to make sure that the platform is very much aligned to what Euro report, for instance, with ECDC, and they will see that the reporting platform for the Euro-specific countries may be different to the other countries, as this platform is meant to make it easier for their country officers to report. Nevertheless, the global reporting will collect the same data and provide a more updated information on the cascade and the burden information for hepatitis. We have provided translation in Spanish, Russian, French. The Spanish version is the word tool and the online versions are already live. The French version and Russian version and the last bits to be finalized this at the end of this week, they should be up and running. So we ask countries to take the advantage of this, so as to be able to allow program officers to better understand the reporting needs and correctly report the data. We have the reporting tool available in an electronic platform, but we understand it may be easier for program officers to report on the paper-based. We strongly recommend, if paper-based reporting is easier for your country, go ahead and do it, and we'll be more than happy to input the data directly to our database. The components of the report include cascade indicators, the burden of infection, that is prevalence, incidence, and mortality. And we have modified the policy questions this year so that they are aligned to what the global health sector strategy is asking, so that this will allow us at the global level and also at region and also at country level to see where they are and rank themselves in relation to the global health sector strategy. So going forth to the indicators themselves, I'll go through in brief of what is asked for countries to report. The first part, we ask for the cascade of care indicators, because this is the only platform this information is collected. So we ask for hepatitis B, number of persons who have been diagnosed up to the end of 2022, and the number of people who have been treated. So this is cumulated number of people who have been ever diagnosed and treated between 2015 and 2022. For hepatitis C, it's the same. We ask for number of people who have been infected to the end of 2022, and the cumulative number of persons who have initiated HCV treatment between 2015 and 2022. We also ask specifically on the burden of the two viral hepatitis diseases, that is the number of persons in the general population who have who have been estimated to have hepatitis B and C, and specifically for hepatitis B, we ask on the numbers for children who are under 5. In some countries, this information may be available in red, and we will impute this number. For the countries who have absolute numbers, we are happy to estimate the prevalence with the denominators on their populations for their countries has reported. For the instance, we ask for a report on the number of new hepatitis B and C infection for 2022, and we ask this number for specifically among people who inject drugs. And lastly, on mortality, we ask for the number of deaths that has been caused by hepatitis B and C in 2022. This indicator may be reported a bit slightly different in Euro, where they report number of persons who have cirrhosis and HCC, and then report the proportion who have been tested for hepatitis B and C. And as mentioned earlier, we have modified how we ask these questions in that region so as to allow countries to be light on how they report. Lastly, on the policy questions, we have added and slightly modified what we ask in terms of policy just to see where countries are. And specifically, we have asked questions, for instance, on an existence of a national strategic plan, if it is available, if it's been approved, or it's been implemented. We understand countries are at different stages of developing the national strategic plans. In some areas, the plan has been developed but not yet approved. In other areas, it has been approved but not implemented. So we ask countries to provide this information in relation to where they are. We also ask on where countries are in implementing hepatitis B PMTCT policies, including testing for pregnant women, if the policy is available, if the implementation is actually happening at delivery centers of service delivery. We also ask on where countries are in terms of self-testing for HCV, which has been the current guidance from WHO. And we do ask on the availability and access of hepatitis B and C drugs as recommended by the updated guidelines in WHO. So this information is important as we track and see where countries are and provide our support strategically to be able to focus our support to countries in relation to where they are and what is the need for the support in specific regions and countries. So how, as mentioned earlier by Daniel, we have stipulated what is the proposed reporting process. We kindly ask countries to prioritize the country data where it is available. So as much as we do have partner data estimates available, if countries do have a system to collect information on patients tested and treated, this information will be prioritized over any estimates available from data partners. Where WHO regions have had workshops or sessions to look at country data, for instance, we understand in some regions they do this in line with the other reporting platforms. This data will be prioritized as it has been validated by the countries and regions. Where that is not available, then existing partner data either from that has been made available to countries from 2019, but we also expect new partner data to be made available in July, and this will be made available to your country offices to look at it, approve it. If not, then comment on the differences, but in any way, look at the available estimates which have been produced with support and together with our partners. And if this data is approved, we ask you to report it. If not, then we ask to comment on the differences so that we can see how we can address the queries. Where this is not available, we understand that regional estimates have been made available to countries and could be used to as a source of data where country data is not available. We strongly ask not to leave gaps in the reportings, as this will will allow us better to understand where countries are. As I mentioned, we know that hepatitis data is available in countries and may be available in specific tertiary hospitals where treatment and testing is occurring, but not necessarily collected within countries. So we know that data is available in patient files and hospital records, but we ask countries to use this opportunity to bring together country stakeholders to look at the data and report it so as to have a better understanding on where they are and better plan their elimination plans. This is our proposed timeline for the reporting. We have developed the tools together with the regional offices and made them available as paper-based and online. We are opening up for trainings for data entries and particularly webinars. Every other Thursday, that is 2 Thursdays in the month, we have 2 hours allotted to any country or regional specific needs to address on go over in details training for the data entry. For instance, in 2 weeks, we'll have a sessions dedicated for the Latin American countries in Spanish to go over their reporting. We're also preparing for a Russian version session to go with to work together with country program offices to better understand what are the indicators, what is the data that is being reported, and better understand what are the available estimates from countries. So we ask countries and regions to take most of these opportunities that we can have time to look at the data and really use the reporting period as a way to evaluate our hepatitis plan and progress towards elimination. The data will be frozen in September 30th, that we expect no further input. And after that period, we'll be working together with the regional offices to validate the data, analyze it, and publish it. We intend to have the country-based data published in WHO sites at the end of the year. And this data will be made available to our partners who may be using it as in relation to their work. For instance, we understand that the Coalition for Hepatitis Elimination will be using some of these data in preparation of the national hepatitis elimination profiles in specific countries. Other funders are also looking ahead to see where countries are in terms of policy implementations. Some of this information will also be featured in the access report that you may be aware that is happening this year, just to see where countries are in terms of license and accessing testing and treatment for hepatitis. This is an example of what we have available for countries from 2019. Some of the countries may have seen this data, and this is what the data will look like at the end of September. We will have data as provided by partners, which will be made available. We'll compare it to what the countries provide, and we'll prioritize country available data. We will then provide the final estimates for the countries and cite the source, whether it's purely partner data or it's country validated data based on what countries provide. As I say, we intend not to have gaps for the reporting, and therefore, we will prioritize country data. But where country data is not available, we strongly recommend the countries to look at the data made available by partners and approve it so that we can use it for our estimates and reporting. I would like to end here, and please note that we are available at the HQ as well as the regional to provide any assistance as you may need for the reporting, so as to be more concise and more accurate and more complete for this reporting round. Thank you very much, and I will now hand over to Echo to play the short video to just show you what the online reporting tool looks like. And just to reiterate, the online reporting tool is precisely the same as the paper-based version. It's the same information. So you can choose to use the online tool or the paper-based, and we'll just take it from there from our end. Over to you, Echo, to play the video.
Access this URL from your email or however you receive it from Diana. It'll open up to something like this, and you'll have an option to choose between which language you want to view it, and there'll be a couple of more which are going to be added here in the next few months. So for now, I'm just going to use English for the purpose of this demo. So if you scroll down, you can see that you can choose a region from the drop down. You can choose which country you're filling in from and your name, your organization, and then just take the survey based on how you're expected to. So these are the questions, and then there are questions where you can put in more textual content, so more paragraphs and some details that you want to fill in. Then you have these type of questions where you can select between options. So either you can choose both, you can only choose one, and but unlike the yes and no questions where you can only choose either like a yes or no or an NA. But yes, these are the questions. And for example, you're here before just this, you want to take a break, you want to go away from the survey for a while. You need to go on to resume later, and it'll say that you can save your unfinished survey. If you don't do this, you might end up losing whatever you filled in so far. So I'll just fill this in and save now. Okay, so Suruchi K. Save now. So it'll say that your survey was successfully saved, and then you can close it. So now you want to go back to the survey, and you hit the URL again, say after a couple of hours or the next day. So what you have to do is everything's going to be blank because you've accessed it all together from a new source. So you go on load unfinished survey, you fill in the same name that you saved from. So in my case, it's going to be this. And then you go on load now. So you see how it was blank before, but now you've got the same details that you had filled. So these are the values that I had put in. And then, yeah, these ones. So I'd only finished my survey till here, and then this is where I stopped. So I can resume from here. And similarly, when you're done finishing with everything, you're done with taking the entire survey, you just go on submit, and it'll say, thank you, your survey response has been recorded, and that's it. If there are any issues that you face, you can write to Diana, and she can get in touch with us, and anyone from our technical team can support. But as far as how to access this technically, this is it from my side, and the rest of the details will be given to you by Diana. Thank you. Bye-bye.
Diana, please unmute yourself.
Can you hear us? Yes, I think
Yes.
we can. Yes, I've posted the link to the tool on the chat. Feel free to look at it and try it out. We feel that some of the policy questions may be relatively easier to start responding to. So we invite countries to start responding to the policy questions and perhaps look again at the data-specific questions as more data become available. I will now hand over again to Echo to project a presentation from CDA they will present to us the models on how the estimates are produced. And we do have Devin online who are willing to answer any questions that comes from this presentation. Thank you.
Hi, my name is Sarah Block, and I'm with the Center for Disease Analysis Foundation based in Colorado in the United States. And I'll be joined on this presentation as well by my colleague Devin Razavi-Shear, who is our hepatitis B lead for the CDA Foundation as well. And today we'll be discussing how we at CDA Foundation provide support for countries for hepatitis data triangulation and reporting of hepatitis estimates. The CDA Foundation is a nonprofit organization that works globally to support countries in their viral hepatitis elimination efforts. Our vision is to eliminate suffering, adverse societal impact, and mortality caused by preventable and treatable diseases. And our mission is to accelerate hepatitis B and C elimination through verified epidemiological data, disease burden and economic impact modeling, development of intervention strategies, providing access to affordable diagnostics and treatments, and then supporting countries with innovative financing and knowledge-sharing partnerships. In 2011, we were asked by WHO to develop a simple model that would estimate the burden of hepatitis C under different scenarios, and the goal was to answer the question, is hepatitis C elimination feasible? And since that time, we've expanded our efforts to also include hepatitis B and hepatitis delta. But at the time, the goal was to develop a model that would be scalable, universal, transparent, could be managed in an open platform such as Excel, and would require the minimum number of inputs. And also the requirement was that it needed to be validated or needed to be possible to have it validated. And over the years, we've developed a model that does meet all of these criteria, and this was kind of our guiding concept as we were developing our modeling. Now, there's lots of different models out there, and for our model specifically, one of the questions we get asked frequently is what inputs are required. So if you look at the table down here, we have two different kinds of inputs that are available for modeling. The first one is country-specific inputs, and then there's also disease-specific inputs. And when we talk about disease-specific inputs, these are things that don't typically change based on the country that you're in. These are inherent to the disease that we're studying. And these include things like transition rates, so between different disease stages. It also includes things like the rate of developing liver-related deaths or the rates of changing treatment or prophylaxis. But then there's also a subset of inputs that are really country specific. And these are, some of them are data that we collect from the countries directly, and some of them are data that we collect through large databases. For example, population by age and sex and background mortality rates are typically available through the United Nations Population Prospects, so we don't need the countries to provide those inputs specifically to us. However, population by age prevalence by age and by sex is really the key input that we need from countries in order to update the modeling. And sometimes this is available through published studies, or it could be available through other non-index journals, local surveillance efforts, studies that have been conducted by the Ministry of Health. So prevalence by age and sex is really the most important thing. Now we do also include viremic rate for hepatitis C. We used to include genotype. We still have it in there, but we don't necessarily need to collect it. The rate of liver transplantation for hepatitis B, we're looking for hepatitis E antigen and also for high viral load, and then for prophylaxis programs as well. During this process, we also collect programmatic data on the number of patients who were treated and diagnosed, both historically and then annually. And historically, what we've also done is collect these data each year from countries so that we can update the model so that it's relevant and the outcomes can be used moving into the future. We follow a consistent and collaborative process to collect our epidemiological data. We then triangulate those data and then use it to model viral hepatitis. And our primary goal here is to gain consensus from all stakeholders. So the first step of this process is to identify experts from the country who have a stake in hepatitis elimination. This can include Ministry of Health representatives, people from public health, epidemiologists, hepatologists, gastroenterologists, infectious disease specialists, and economists as well. Now, an example from one of the countries that we worked in back in 2019, we essentially convened a 3-day meeting where we were on site, and the meeting was co-sponsored and supported with CDA Foundation, WHO, and MSF. And then we also had representatives there from the Ministry of Health, quite a few of them, from many different programs. So we had people who were involved in treatment, people who were involved in immunizations, people who were involved in other preventive areas and surveillance as well. So all of these individuals were together at the same time having the same conversations. And then we also included local experts from the community. So we had providers who were seeing patients, we had hepatologists, gastroenterologists, people from the private sector, so that we could get an accurate picture from the whole of the country as opposed to just an idea of what was happening in the public sector or just an idea of what was happening in the private sector. Now, before we attended this meeting, our team conducted a literature search, and the goal of this was to identify any published data that might be available for the country so that we could go into this with some level of information so that the collaborators weren't expected to provide all of the information. And what our team did is we looked through the literature that was available, we put all of it together in slide decks, and then we also did some estimations to figure out what might be the best sources of data based off of our standard data scoring tables, and then also trying to figure out how some of these data interrelate and do some data triangulation work. For example, if there's information from a diagnosis registry or a surveillance registry that suggests there would be 100,000 people in the country who have hepatitis, and then a prevalence estimate that suggests that only 50,000 people would have hepatitis, that's obviously discordant, and we would want to understand which of these two pieces of information is correct or where we might need to make adjustments. So we do a literature search in-house, and we populate the model and do our best to get a starting point for our collaborators to respond to. Now next, we have a meeting to review the inputs, identify any data gaps, and talk through every source that we considered and that we used in the discussion and in the modeling. And we have detailed discussions around each of these data points and essentially come to consensus on where we want to move forward for the next input for the model. Now the next step of the modeling is to essentially take all of that information, put it into the model, do some more triangulation, collect any other data that may be available or that we may need to go search down. Sometimes this involves our collaborators going out and collecting data from their local hospitals or their systems and then providing that back, and then we update the model. We then have another meeting, to develop strategies where we not only review the inputs again, but we also start to work on building modeling scenarios and discussing the outputs associated with this. And then after all of that is finished, we typically put together a report, or we can also put together a publication. If we do a report, we usually just send that back to the Ministry of Health and our collaborators, and they can use that for their own needs. Sometimes that's involved in more reporting or putting together their own national surveillance or action plans for hepatitis. And sometimes that's just for their sake for developing abstracts and submitting manuscripts. Now, the quality of the data available for hepatitis C and hepatitis B varies quite substantially. However, there is a lot of data that's available, and most of it just has to be searched for. So as many of you know in your countries, the data may not exist in one centralized location. However, that doesn't mean that there aren't physicians or academic centers or groups that have been collecting data for a long time. And so part of what we want to make sure and do is centralize all of that and find a way to make it all useful for our modeling efforts. Now, most data in lower middle income countries have not been published, or they're published in a local journal as opposed to one that would be indexed on PubMed. Oftentimes, national serosurveys are published as a report on the Ministry of Health website as opposed to something in a peer-reviewed literature. If we're looking at treatment data, a lot of patients are treated at tertiary care centers as opposed to within primary care centers, and so there may be robust historical data in those centers that's available, but it does need to be collected. Similarly, some countries may have premarital screening data for people who are in the age range of 17 to 65. There may be pregnant women screening data available that provides prevalence among women of childbearing age, and there also may be data available for military recruits that provides prevalence estimates among young men. One nice point about modeling is that it allows us to use prevalence data from one point in time to calculate prevalence at another point in time. And the example I'm showing here is from our recent hepatitis C publication. So the table on the top is from the supplement, and this actually shows the data that goes into the model. And for Australia, you can see that the published study estimates about a 0.78 or 0.8% RNA prevalence in the year 2015. And then the second table on the bottom shows the table that's actually in the main text of the manuscript, and the modeled estimate, as you can tell, is pretty much identical to this. So it's been rounded, but it's basically the exact same estimate in 2015. So data in for Australia starts at 0.8%, and that's what the model says for 2015 as well. However, when we look at the estimates for 2020, we do see that there's been a change from the 0.8% to about 0.5%. And the number of remic infections has changed as well. And this is kind of the formula available for this. So we start with 193,000 remic infections in 2015. We add the number of new infections that occur over time. We subtract out the number of liver-related deaths, we subtract out the number of background deaths, and we subtract out the number of cured patients. And this gives us our estimate in 2020. And this is a really common reason that we've seen where countries may say, you know, we have a prevalence study and it's X% in this year. And we say, yes, actually, our data are not discordant with that. We just have a different publication, or we have different data coming out of the model that takes that information, kind of incorporates other information like diagnosis and treatment, and then gives us a new modeled estimate for the most recent year. Another reason that the data sometimes look different from the raw published study to the data that are coming out of the model is that in many countries, the published estimates need to be adjusted to some degree to reflect the general population. And the example I'm showing here, again, is for hepatitis C, but essentially the table on the left would be straight out of a publication, and it represents data in people who are between the ages of 15 and 59. But we know that there are people in the country who are over the age of 59 and people who are under the age of 15. And so in the figure on the right, what you see is the box indicates where we have used the raw data from the publication, and then we've made assumptions about the data under 15 and the data over 59. And we do all of this usually in discussion with our expert panels to make sure that we are appropriately making those assumptions. But the impact of that, it can be quite different. So what you see is the published estimate at the top in this table is about 3.5% in people between the ages of 15 and 59, or about 280,000 cases. Now, the first adjustment that we make is to expand that to all ages. And as you notice when we do that, the prevalence drops as a percentage because we have a bigger denominator, but the case count doesn't actually go up by a lot. And part of that is because the prevalence in the younger ages is much lower, and the number of people in the older ages is also smaller. Now, the next adjustment that we do is we adjust for viremia. So this first estimate was in antibody positive or seropositive cases, but we want to know for the modeling how many people are RNA positive, and also it's important for our programs because these are the people we will be treating and hoping to cure. So we make an adjustment to account for viremia. And then the last step is the modeling. So that all of that is done is just done on the raw published data to make that estimate in 2010. And then we can use the model to account for time, including not only mortality, cure, and incidence, but also population growth. So you notice between 2010 and 2020, the prevalence as a percentage goes down just a little bit, but the number of cases in this country would actually go up just a little bit because of population growth. Now, we frequently use multiple sources to consider diagnosed and treatment data, and in some countries, combining sources can be necessary as well. So again, the table that you see at the top is based off of our latest publication for hepatitis C, and you'll notice that we have the annual number of patients initiated on treatment, the year when those data were available, and then the type, the source type, and the source associated with those data. Similarly, we have diagnosis data and the sources associated with those, and the people who are newly diagnosed each year and the sources associated with those. So the main point to show here is that a lot of different types of data can be used to estimate diagnosed and treated. In order of our preference internally, obviously a national notification system would be the best, gold standard. But in the absence of that, we can use, for a diagnosis, we can use peer-reviewed literature, blood donation data, and expert opinion. For treatment, we can use national databases as well. We can use drug sales data, government reports, estimates from major treatment centers, or drug suppliers. Now, one of the things that we do at CDA when we collect these data is we're always triangulating to see how do they fit in with the other information that's been provided. So in some countries, we've had cases where the number of diagnosed patients or the number of patients available in a registry would actually exceed the number of people estimated based on a recent prevalence study. And in that case, we usually spend a lot of time going back to the country and saying, hey, you know what, these two different pieces of information are giving us different insights. So how do we triangulate, how do we work with this information and all the information available to get an accurate picture for the country? And this takes a considerable amount of time. So a couple of considerations when we're looking for diagnosis and treatment data is that final estimates need to really report both the public and the private sector. So for modeling, we're using these data to change the prevalence over time. And if we're only capturing data from the public sector, and we don't have the information around people treated in the private sector, we may be overestimating the number of cases still needed to be treated in the country. So it's important that when we're going out and collecting our information around treatment, that we're trying to capture both of these different sectors. Sometimes that means talking to providers at tertiary care centers and just simply asking how many patients have been treated in your center over the last 10 years or so. And then they can aggregate those data over time, and we can look at those compared with other tertiary care centers and make some adjustments as needed. But it is important to try to collect those data as much as possible. Also, this may be specific to our work at CDA Foundation, but in our case, expert opinion does not always mean without data. So in any of our publications or on our website, if you see something that reflects expert consensus or expert opinion, typically those informations have been provided with some level of data to support. So perhaps it was one single hospital or center that provided data, but when we've used that data in conjunction with some level of adjustment, we want to make sure and convey that there is some uncertainty in how that is being incorporated.
The progress model is our fully dynamic hepatitis B disease burden and transmission model. And for this, we follow most of the same protocols that we do for hepatitis C, but of course we do need some additional inputs. The first one that we use is the hepatitis E antigen prevalence in pregnant women. We do prefer viral load, but we chose E antigen among pregnant women as it was the most available data point within the literature, as well as it was the only population that was regularly non-biased relative to, say, patient cohorts or diagnosed patients as well. Now, we also need data for prophylaxis measures. For the 3-dose coverage or greater than 3-dose coverage, we use the WHO UNICEF data, and that tends to work very well. Now, for timely birth dose, so that's the first dose given within 24 hours, we do start with the WHO UNICEF data. However, there are countries that do need to have adjustments. So even though there have been some changes to the reporting system, we do know that there still are countries that are reporting first dose given within 30 days, first dose given within the first week. And so we want to make sure that for the model, we're using the right inputs. We also are interested in general population catch-up campaigns. So say if everyone under the age of 20 was vaccinated, and this data we usually are able to pull from publications and Ministry of Health reports. Now, the other two large interventions, hepatitis B immunoglobulin and antiviral treatment of pregnant women, there is generally little data published about it. So what we do is we work with countries to look at their guidelines and then talk through the steps with them. So in-facility births, of course, impacts accessibility to HBIG as well as timely birth dose. Having the percentage of pregnant women who get prenatal care, that helps determine antiviral treatment of pregnant women. But of course, also we need to know what proportion are screened for hepatitis B, and of those who get surface antigen tests, who get a viral load test for the current guidelines. Now, lastly, we also need to look at targeted mother-to-child transmission interventions. So in some countries, they only provide coverage to infants born to surface antigen positive mothers or infants born to E antigen positive mothers. While this has changed greatly, this still does exist, and in some countries, they still maintain higher coverage in these groups that are most at risk of acquiring mother-to-child transmission than the general population, and we need to make sure we incorporate that as well.
Now, once we have consensus on the inputs and the outcomes of this process of collecting data, the model can also be used to evaluate what-if scenarios and estimate annual programmatic needs. This is an example from Pakistan that we conducted it was just published this year. And on the top, what you can see are graphs from the model that show the forecasted standard of care over time, as well as the forecast for total infections and liver-related deaths if we were to achieve the WHO elimination targets within this country. And then the table at the bottom shows what we would need to do on an annual basis in order to make those different scenarios possible. So you can see for screening and for the number of antibody screening tests, number of RNA screening tests, number initiated on treatment, new infections, and essentially the number of new infections that need to be prevented in order to achieve the elimination goals. One important point with our work here at CDA Foundation is that every collaborator that we work with is invited to co-author in acknowledgement of their substantial contributions to the work. So we don't publish data without the consent of our collaborators. We don't publish any of the raw data without their approval. And we may include modeling estimates as outcomes from the work. However, we want to make sure that they get cited and referenced as well for the work that they've done. So all of our publications do include all of our collaborators, or at least they're invited to participate if they would like to. In summary, data triangulation, knowledge sharing partnerships, and annual requests for data can directly and indirectly improve surveillance. Data collection and triangulation for modeling can help countries think through the data that they need to monitor hepatitis elimination. It's important to mention that a model can't be developed without data, and so it's important to have the data from the countries in the first place to do this work. But also the models can provide substantial value and insights into what needs to be done and how programs can be supported moving forward. Typically, the work that we do requires about 10 hours of time per collaborator per disease area, and then the rest of the work is conducted within our team, and we do a lot of data triangulation internally to try to make sure that all of these pieces of information align. Additionally, in the past, we've been asking our collaborators for annual estimates to update the model with. So this is typically just how many people have been diagnosed, how many have been treated, have there been any changes to your programs that we should be considering. And in the process of asking for this year over year, it actually provides incentive for our countries to have some standardized way of collecting and reporting on these data. So just by being asked for it over time and knowing consistently of what's being asked for, it makes it a little bit easier to collect it as things move forward. And then lastly, experience with experts across health systems and countries and having a goal internally of transparency and collaboration can help serve as a conduit for knowledge sharing. So over time, we develop insights that come from one country, and then we can use those insights to help another country with their elimination programming. So I'll stop there. Thank you so much for your time and attention.
Thank you, Devin, on behalf of Sarah, and thank you for being here, Devin. If I may invite some few questions to the presentations and specific for this presentation, should there be any, so that we can go to the poll questions. Please raise your hand, unmute yourself and speak out. But as we're waiting for questions, perhaps I could invite Daniel to speak a bit and comment on the HS2 strengthening and their plans or requests that have been requested in the chat briefly. Over to you, Daniel. You're on mute, Daniel.
So just to say thank you, we hugely welcome those requests for support. So part of the aim of having a slightly longer window is to be able to pick up some of those strengthening measures. We have some priorities for strengthening. So certainly the starting point is person-centered treatment data, where we can collect and triangulate treatment data within a country, a survey of burden, so that you have at least a data point for burden, and then putting that into the type of modeling that gives you the estimates. But then the next stage is improved person-centered forms and data that can go more routinely into the DHS2, and some of the mortality data, some of the mortality sequela that needs to be strengthened, including cancers and cancer registries. So we hugely welcome those pieces, and we will discuss them with our AFRO colleagues so that we can see what parts we can support. And please, any other requests, do put them into the chat or send some notes through to the regional staff, because coming out of the hepatitis reporting, there is a box where you can fill in what your priority requests for TA are, and that will be the basis of how we support countries in the coming year. Thank you.
Thank you, Daniel, for that. We're still waiting for any other questions as they come. But in the meantime, if I may just mention again, we have booked Thursdays, 3 p.m. to 5 p.m. Geneva time, every other week. So we had a session last week. We have the next session next week. What we do in this session is go over the reporting in terms of the technical content and where countries have specific questions. We recommend regional specific sessions so that we can have one or more countries in the session, and perhaps it also becomes a better learning, country-to-country learning platform. We will have this webinar in Russia in the near future. We're speaking to the Euroregion for this. And then we have on June 8th, a session in Spanish for the Latin American countries to go over their contents in Spanish. So we do invite regions and countries to take opportunity of these sessions. It's available 3 p.m. to 5 p.m. for countries who want specific support on this. And we're happy to provide that as we go. As we wait for anyone else who has a question, so would like to speak, please be free. But
Diana, there are a couple of questions in the chat. I think maybe one from the Philippines. I don't know if you've seen that already, or Daniel or Devin. We have ongoing viral hepatitis estimates. Hopefully we can ask assistance for progress model training. I don't know. Then there's a question on hepatitis Delta, if it can be reported. I think it's a nice one because we're just about to examine if WHO should recommend testing and diagnosis of hepatitis D more systematically in hepatitis B, but it's maybe not included yet in the system, but are there ways to report it nevertheless? This is a very nice question, I think. And then Mugaga had questions, but I think they've been answered by you. Otherwise, Mugaga, please, you can raise your hand and come in if you still have remaining questions.
Thank you,
Yes.
Thank you, Nicholas. No, they were handled appropriately. Thank you, colleagues. Thank you for the good work. I've even saved the tool. I will be answering with the country team, Uganda country team, progressively until we deliver before the deadline. Thank you.
So thank you.
thank you for that.
And for the tool, Diana, in the letter there is the points of contact, and we for Delta there is a bit where you can add qualitative comments both on the data and the reporting, so you can add anything there, and an important section where you ask for M&E strengthening needs, so that's where that could go in. We've tried to keep the tool as simple because as simple as possible, because the important bit is to really put in data from countries and to get high reporting completeness and to get officially agreed figures so that we can align partners to support the country. But if you've got additional stuff, of course, put that in the contextual boxes that are there.
Maybe, Daniel, if you allow me one comment, is that I think the policy section has been a little bit extended this year, but I think it's good to give the rationale for that, because this has been really a key role in HIV, for example, from your unit. And so I think there's maybe a little bit to report against, but it could be really very important information as well coming from that section.
Yes, we've worked on the policy questions in the team, and we're trying to see how best we can have policy questions answered as they are in the GAM reporting. As countries may know, they do answer qualitative questions on NCPI, which are specific to HIV. So we would wish to have a better understanding on where countries are in hepatitis, and therefore we try to have these phrased or mirror and see how we can better get intelligence on what countries are doing on viral hepatitis. And of course, they are aligned with the updated guidelines for WHO, including self-testing, including delivery of services and primary health care services. So trying to see where countries are and then, of course, in relation to what the Global Health Sector Strategy for Viral Hepatitis has recommended. We have a raised hand. Maurice, if you could unmute yourself and speak.
Oui, bonjour. Je suis le docteur Mbela Maurice Rocher. Je ne sais pas si vous m'entendez.
Good morning, good afternoon. I hope you can hear me.
Je suis le ministère de la Santé du Cameroun.
I'm working for the Ministry of Health in Cameroon. I am in charge of the national program here, working on the elimination of hepatitis. So we are working on implementing a strategy and a policy. So we are kind of early on in the process, but first of all, I'd like to thank the WHO for this, for organizing this meeting. And I think data is essential, and for us, there's still a lot of data missing in Cameroon. And I understand that data is important if, of course, we want to conduct the advocacy campaigns and also adapt our strategy to eliminate hepatitis. I just would like to come back on the program. So I understand you were asking for some indicators, but for some
Ou bien collectés qu'à partir des enquêtes.
those can only be collected based on some studies, and it's not always easy because you're also asking for a lot of data at national level. And, you know, it's sometimes difficult because in a country such as Cameroon, very often the data collected or that is very fragmented. And I'm not sure the data is really representative of the situation in the country. We need to also say that for Cameroon, there is a huge disparity between countries on the prevalence, but also the burden of the disease. So I think it's very difficult when you're trying to collect data at national level. I don't know that this actually here is a good way to have a clear picture on the situation in the country, at least for us in Cameroon. So what I'm just trying to say is, like, I'd like to call for help to the WHO if you can help us providing technical assistance for collecting data. And we would be really happy to cooperate further. We use a DHS2 since 2018. And I know that there are already some indicators for hepatitis in DHS2. And this is information we use, but this is for specific populations such as pregnant women and screening for pregnant women. We do not collect data for prophylaxis for pregnant women. And we also have some information when it comes to blood samples, blood banks. But again, it is extremely difficult to have a clear picture. And we don't really have a system in place with like standardized tools to collect the information. And sometimes I think that would be here very useful to have a better connection to other programs such as the HIV or other programs in charge of chronic diseases like the cancer also registry to really understand the burden of hepatitis. So we have still a lot of work to do in Cameroon, and sometimes it's overwhelming and it's difficult to know where to start. So we need, of course, tools. So we are very interested when you talked about tools, but we will need here to have more information and maybe more training on how to use some tools. Sorry for being so long in my comments, but thank you very much for your attention.
Casimir, tu veux peut-être, je sais pas si
Casimir,
tout le monde a eu la traduction.
thank you very much. So the translation was available in English. I don't know if Casimir, you'd like to answer, because this is a kind of a question. This is a very interesting comment from our colleague. Yes, if I may. I mean, Casimir, you can also take over, but I think it's great to understand and have more information on the system in Cameroon and all the work on the program and DHS2. Thank you for all this information provided. First, you're right. For the data, we need, of course, information on treatment. So we really need to see what is essential. So this is about the strategy here. But then it's important to also have and use the model we've created, a better information on the program data. So I would say those are the two priorities. And after that, you're going to have to use the data at national level. I'm always kind of surprised by the progress also. And I think you need to use that, and that's very important. That's really one of the priorities. So the programmatic data on treatment and using the standardized tool and then using the data. And of course, when you need to strengthen the system, I agree, this is a very important part. And therefore, we need to talk about the prevalence of the previous years using that model and update that model. But the most recent data for hepatitis B and C are key for this reporting. But thank you very much for all the information on the background in Cameroon. And I think it's very relevant for this session. And of course, I'm sure we could do more. And I'm sure there's a lot of data available in countries, but sometimes it's just very fragmented, as you said. Thank you very much, Casimir. Thank you, Daniel. And thank you very much for sharing your concerns and sharing, of course, this overview of the situation in Cameroon. I think we need to look at how we can improve the data collection using routine processes so that it's not an additional burden. And I believe you're right, you talked about the pragmatic data. And I do believe that it's going to be easier to start that way. But it's also about the different policies. You talked about already about the work that is done with the screening of pregnant women. And I think we could also then add additional information on prophylaxis and strengthening these data collection processes. So when you will start filling in the data in the reporting platform, of course, we would like to provide some additional support to collect a comprehensive set of data. We understand that sometimes data is available, but not centralized, and that's one of the major challenges. So we need to make additional efforts to really involve all the stakeholders, and that can be the public sector, the private sector, the primary healthcare, tertiary healthcare, and I think this is possible. Thank you very much. Nicholas, you've got the floor. And Daniel, I think that also our colleague from Cameroon mentioned here the national surveys. And I agree, for some indicators, They come from national epidemiological national surveys. And that's true that those are not necessarily conducted very frequently or regularly, but I know that in Cameroon, this is something that is done, and it's a process that is pretty solid. And before we close this session, would you like maybe to add any more information, Daniel?
Okay, oui. Les trois,
Yes. Priority one is, of course, the program. So that's why we need to be updated on treatment. But the second point is really to understand here the burden at national level. And to do so, we need to plan, schedule this type of survey. But of course, it's not something that changes like every year. So we need this data every 3 to 5 years only. And that's why we worked with a CDA to use their model here to better understand the needs and to enable extrapolation based on these indicators. So there is some information already when it comes to the CDA. But yes, if a survey has not yet been organized, I think it's important to do so, epidemiological survey. And maybe there's already been other type of surveys on, for example, HIV, other opportunities, to maybe add a pillar on hepatitis to try here to collect more information if there isn't a dedicated survey. So, and every 3 to 5 years, because that was your question, Nicholas. Thank you very much, Daniel.
You can change your translation button if you need to. Diana, do you want anything before we close? Anything you want to insist on or say?
Mainly just to acknowledge for those who had come in particularly for this session, just to be familiar with the reporting system. Thank you very much. Thank you, Daniel, for taking us through. Thank you, Devin, for the excellent presentation. This material will be shared and made available at your leisure. You can listen back, especially to the presentations, to be more familiar with the content. As noted earlier, we do have bi-weekly, every week sessions on the reporting. We understand that the memo has not gone to other countries, and especially in Europe, we're waiting for the Russian versions to be made available. But as it becomes more available, we invite countries to take advantage of the sessions to get more times to understand the reporting, but also to have a time for the country to look at its hepatitis data and see where they are and where it needs strengthening. We understand that the partner data will be made available, and it will be a good place to start the dialogues within countries on the estimates and approve them or discuss and provide comments on where they disagree. So looking forward to more interaction through other platforms, and do reach out to us, to me directly, should you need more guidance and more support during the reporting. Thank you.
Perfect. I think that's very good that those training sessions exist on a very regular basis. Very important topic again. Thanks for joining. It's really uniquely important that WHO can report regularly on global hepatitis response and epidemiology. Very important role of the colleagues. Just to say thank you again, to tell you that the next session will be on the 8th of June, the same series here. It will focus on setting up sentinel surveillance sites to monitor mortality from hepatitis B and C. So it's another subject of strategic information, and we hope you can join us again, and maybe other colleagues can join for that very interesting session. If you have follow-up questions, as it was mentioned in the chat, you can write to Diana and other colleagues. Don't hesitate. We will try to support you for that exercise. Last but not least, there is a short survey that ECHO has paste it in the chat, which we would really love you to take. I know that those surveys is always hard to find, but I think with that we leave you we leave you to your day or to your evening. And thanks, Devin, for joining so early in the morning for your time, and all the best.